Here, these are my disclosures. So I think the idea of everyone working together as a team to get things done faster and better is not new. I think that we're all very familiar with this. You've seen versions of this slide all morning, and I'm just going to give you another one. So this is essentially this is WHO global can data. This is esophageal cancer, and I think it's quite clear that esophageal cancer is a problem in the U.S., certainly to a lesser degree in Korea comparative to gastric cancer. We see, as you know, particularly GE junctions, where in Asia they see more squames. But if you take this and you look at stomach cancer, and I think we've seen slight variations on these numbers, but again, this is essentially per 100,000. And you see this is Korea, highest, and then this is US. So I'm a GI medical oncologist, and I focus pretty much exclusively in stomach and esophageal cancer, which, believe it or not, can actually be a job in the US because at high volume centers, this number does make enough patients for me to have a job. But it's places like Boston and New York and LA and City of Hope in particular, where there are concentrations of enough patients to do concerted gastric cancer work. But we still need help, and if you want to do work, you got to go to where the disease is. And Korea has sort of been our go-to collaborator. So why is this important? Are these studies different? And I think we've seen this repeatedly. So this is, you can pick your phase 3 trial in advanced gastric cancer, and you'll see a very similar phenomenon. So this is the forest plot. And if you look at Asia and the US, you see that this pattern is repeated throughout trials. Asian patients are doing better than their Western counterparts. The question is why? So is it a biology? Is it environmental? Is it a combination? So there's some low-hanging fruit. You can look at, are these tumors molecularly the same? So as you saw from Dr. Kim, some immunotherapy results. When you break this down and you said, oh, sometimes we see the Asian patients doing better, does that mean that they have more of the marker? So therefore, that's why they're doing better. In fact, that's actually not the case. So here you see that the rates of PD-L1 staining between Asian and non-Asian patients are comparable. So it can't just be this biomarker. Then you can say, well, maybe the immune infiltrate around the tumor is different between Western and Eastern patients. And here you actually do see a little bit of differences. So maybe PD-L1 is not the best biomarker. Maybe it's the actual immune infiltrate. But what this doesn't tell you is how well the cells that are there are functioning. So these differences are not substantial enough to explain difference in outcomes between Asian and non-Asian patients. So then, if the tumors are not biologically different, are our colleagues in Asia just better at taking care of gastric cancer than us? And the answer may be yes. And so this is an interesting paper looking at what's called post-progression survival. So these are people who progressed after first-line therapy or after second-line therapy, broken down by rest of the world, Japan plus rest of the world, or Japan only. And I suspect if the same analysis was done on Korean patients, you'd see exactly the same figures, but routinely, red is the Japanese only patient. So you see the post-progression survival and the percent of people who are getting therapy after first line. Because remember, progression-free survival is a measure of essentially how well the drug is working. Overall survival is confounded by subsequent lines of therapy if people are treated after progression. And so progression-free survival between Asian and non-Asian is generally the same, but the overall survival is generally better in the Asian population. And this may hint at some of the reasons. So first, more people are getting therapy. Look at the numbers for the rest of the world. It's kind of embarrassing down here how few people getting therapy after second line. Whereas if you look in Japan, the majority of people. And so if you get therapy, you live longer. That's essentially the gist of this figure. What about sequencing? So Korea has published the Asian Cancer Research Group, the molecular classification of gastric cancers, and the Cancer Genome Atlas, which is a largely non-Asian cohort of stage 3 patients and 2. And when you compare the Asian and the non-Asian genetically, there's essentially no differences. Little higher rates of PI3 kinase mutations, which may actually have a poor prognosis. So that doesn't explain why the Asian patients are doing better, but we routinely see improved outcomes. So the level of collaboration for industry-sponsored clinical trials where the drug company is paying to do the trial it's pretty good. You know, essentially we enroll and Asia is enrolling significantly better than us because they have more patients. But there's a lot of opportunities for correlative work from some of these big data sets. So just broadly, what can you gain from collaborations? Of course, you get your results faster. An important thing is that if, you know, there's nivolumab is probably a good example of a trial that was done entirely in Asia and was positive. So the drug is approved there, but the US FDA will not approve a drug in the United States without enrollment from US population of patients. So you need a more globally representative cohort, and certainly that's why, you know, you have to enroll outside of Asia in most of these trials. Certainly there's complementary expertise, and then we can get stuff done with rationally designed trials. So we sort of embarked on starting a relationship with Jae-Yun Lee at Samsung Medical Center now several years ago. And we weren't really focused specifically on doing clinical trials together because one, that Korea is so good at doing gastric cancer clinical trials anyway. You know, we weren't going to add a huge amount to that. But what we could add was starting to look at some of these data sets because they collect such good data. And so these are just some of the representative papers highlighting that Korean and US collaborations are quite possible in gastric cancer. And so you see Dr. Chow, who's not here today, is at City of Hope, who's also a big sponsor in this conference and has been a great colleague and collaborator for several years. Like Dr. Kim said, we also looked at ATM, but not as a therapeutic, but as an independent prognostic marker, and then looking at some rare subsets of gastric cancers because there is maybe a little bit more PI3 kinase pathway activation in Asian patients. So we have several ongoing projects. This was just published, I think, yesterday. Again, between our team, we need to have an acronym for our team because all good teams need an acronym. But again, when you're looking at rare variants, you know, FGFR2 may only be amplified in 3 to 5% of stomach cancer patients. It's really helpful to have teams that can pool all their data. And so we're actually working towards collecting our data in a complementary way so it's easier to pool together. So we're capturing the same data elements between the US and in Korea. This must be a colleague of yours, Dr. Lee, another gastroenterologist at Samsung, who actually led this project. This is looking at some fundamental questions, which are, if you take an untreated non-stage 4 patient and you biopsy multiple regions of the tumor, are there differences? And certainly there are clear, this paper is under review. Certainly there are a lot of similarities between, this is the inner quadrant and the outer quadrant region of biopsies, but there are a lot of changes that are private to only one or the other. So basically trying to ask the question of heterogeneity at baseline and then think about what we can do. So we have some great endoscopic collaborators in Korea. And this is data led by actual Joe Chow at City of Hope, saying what's the clinical impact of this? So the more heterogeneous your tumor is, these are patients who Dr. Wu probably operated on a large portion of them, but these are people who had resected stomach cancer, non-metastatic. And what you can see here is that people who had more clonally mixed tumors, so this is people who have heterogeneous tumors, so these are some common biomarkers down here, they do extremely poorly, so all their tumors come back. Whereas if you have a more homogeneous tumor, so a low clonality, you do much better. So we're thinking about how to make this collaboration bigger and try to address some meaningful questions in gastric cancer. And like we've talked about, why have collaboration? Certainly more broad pathway to approval. Team science is the best way to get stuff done. Plus, we just like hanging out. How do you do this? Well, co-developed protocols. I think, you know, we learned a lot from our counterparts about the regulatory environment in Korea and the US are not exactly the same. So trying to design protocols which can be activated in both countries without a lot of modification is important. Certainly we meet at any time we're there. I had a long experience with soju when I went to Seoul, dangerous. And then we try to do this, we're trying to make this happen now. And so certainly we'd be happy to work with as many of you as possible. I think there's some really, really cool opportunities that I thought of just from thinking, from hearing about the screening program for, basic pathogenesis. So I don't know if you collect blood on patients who are getting screened at their screening endoscopies, but you certainly know the patients who go on to get cancer. So you can sample that blood, and we could think about joint projects, some expertise about analyzing that blood, looking for actually markers of people who may go on to get cancer. So better prognostication and predictive biomarkers perhaps complement sort of the targeted screening that was discussed this morning. So this is really the end of my talk, just to keep it short. So how do you do this? I think this is a huge step. I would love to have more meetings like this. I think to the patients that are watching the YouTube stream, this is a critical message actually to advocate for yourself. Just ask questions. We know that people who are treated in high volume centers do better. And certainly the centralization of gastric cancer care in Korea is a shining example of this. In the US, our care is very spread out. A lot of community oncologists will see 2 to 4 gastric cancers a year. And you certainly can't know the data as well if you're only seeing that small number of patients. Same for surgical volume. Certainly the surgical expertise, a high volume US center might do 50 cases. High volume Korean center might do 1,000 cases a year. I mean, we've seen the numbers. It's staggering. And so patients can learn from that and certainly advocate for themselves to get to a high volume center. This is my final slide, and I'll